So these are my first impressions when I see a patient with liver cancer in front of me. Uh, I'm very uncomfortable treating a liver cancer patient because for liver cancer diagnosis, biopsy is not required. There is some confusion, and it is difficult to treat because the patient has both liver problem and cancer. And if there is any response, I do not know how to assess response. So whereas if I see a breast cancer patient in front of me, oh, these patients are really going to do well because I have excellent surgery. I can take off the breast. I have prosthesis which I can get in. I have targeted treatments, excellent responses. So this is the difference between how I feel if a liver cancer patient sits in front of me versus a breast cancer patient sits in front of me as an oncologist. So liver cancer, uh, the chance of chronic liver disease is increasing day by day because not because of alcohol, not because of hepatitis, but because of non-alcoholic fatty liver disease. I'm sure if we do ultrasound liver for all of us, 90% would have fatty liver right now. So the chance that we will land up with cirrhosis is very high. So 1/3 of us can land up with chronic liver disease at some point of our time, and 1/3 of these cirrhotic patients will develop cancer. Therefore, the chance of picking up liver cancer is increasing because of the screening techniques we are having. The problem with liver cancer is the outcomes are decided not because of cancer, but because of cirrhosis. The patient mainly has symptoms because of liver dysfunction than due to cancer. So if you look into other organs, like a breast cancer, the problem is not with the breast. So it's not a functional organ. Therefore, the whole problem is because of cancer. Whereas liver cancer, the problem is liver is a problem. So therefore, this is a disease which has two problems. One is liver failure and the other one is liver cancer. So because of this, it is a challenge to treat this particular disease. So what are the usual symptoms, when a patient with liver cancer sits in front of me and says, my abdomen is full, there is edema, there is melena, I cannot eat, I am always sleepy, I have jaundice. These are the symptoms. I do not know whether these symptoms are because of cirrhosis, whether it is because of cancer, or whether it is because of treatment. When I put them on drugs like sorafenib, they trouble them more. So it is very important to classify what are the reasons why the patient is actually having symptoms. So as I said, virus is of course an issue, but non-alcoholic steatohepatitis is the most common cause, and males are the ones who have 3 times more chance of having liver cancer than females. So these are the common clinical features. A patient with cirrhosis of liver, otherwise asymptomatic, if the patient develops decompensation, always do an ultrasound to find out is there a development of liver tumor or cancer in that particular patient. So what we do is all patients, who are at high risk. What are those high risk patients? Patients who have cirrhosis of liver or who have a chronic hepatitis infection, especially if they have a higher viral load, they should undergo 3 to 6 monthly ultrasound. And if the size of the lesion is less than 1 centimeter, then you go ahead with doing this for 2 years and follow up. If it reduces, nothing needs to be done. You can get back to it with 6 monthly. If the size is more than 1 centimeter, you can diagnose this with only imaging. No biopsy is required. So liver cancer is a disease where there is no need for a biopsy. Why there is no need for a biopsy? Because the liver cancer has a differential blood supply. The whole liver has predominant blood supply from the portal circulation, whereas liver cancer has predominant blood supply from the hepatic arteries. Because of this differential blood supply, there is a typical appearance on a triple phase CT scan. Early filling and late washout is what we see in a triple phase CT. So liver cancer is a radiological diagnosis, and therefore there is no need to do a biopsy. So in fact, we have different categories, what is called as the LIRAT score. It is a liver imaging reporting and data system. So if it is LIRATS 5, it is definitely HCC. Okay. So when should you do biopsy in a liver cancer? Okay. Only if it is a normal liver, then you should do a biopsy, or it is suspicious, or you are thinking it is a metastatic disease, only then you will do a liver biopsy. Otherwise, for diagnosing liver cancer, you can completely avoid biopsy. In fact, you should not do it. Okay. So this is the BCLC staging that we usually use. To just simply say, if the size of the lesion is less than 2 centimeters and the liver is fine, you just operate it. And then if the liver is diseased, and I'll just show you what are the indications. When can if I have a liver sol, let us say a 2 centimeter liver sol is there, when can I operate it? This is called as resection. Hardly we see these patients. We see patients who are usually having BCLC-B or BCLC-C. But if you see a BCLC-A or a very good risk patient, if it is solitary, no vascular invasion, good liver, no portal hypertension, resection is better than ablation, and you must resume to antiviral therapy if it is due to virus. And there is no adjuvant treatment required. There is something new that is coming up in the adjuvant setting. So we have got immunotherapy like atezo-bev. It has just improved the relapse-free survival, and there is hepatic artery infusion with FOLFOX. This also has shown some DFS benefit, but no overall survival benefit. Therefore, it is not yet the standard of care. So then coming on to liver transplant. With liver transplant, you will treat two things. You will treat cancer and you will treat liver disease both in one go. So what is called orthotopic? Orthotopic means putting a transplant in the same region where the liver was there. Either you can do what is known as a deceased from a cadaveric liver transplant, or you can do from a living donor liver transplant. When do you do that? When the size of the lesion is less than 5 centimeters, or if it is 3 in number, less than 3 centimeters, only then you will do. If you are able to do this, you can attain a 5-year survival of nearly 75%. The problem is finding out donors, therefore, an anticipated delay is expected. On those occasions, you can do some bridging therapy with local liver-directed therapies. Post-transplant, we would like to use as much less immunosuppression as possible because of the risk of relapse. So, supposing it's more than 3 centimeter, more than 4 centimeter, multiple, then we opt for what is called as liver-directed therapies. We use RFA, microwave, TACE, TARE, EBRT, and so on. And the liver limited, with a limited disease burden, we will prefer liver-directed therapy. If it is a large disease burden, then a systemic therapy would be required. Okay, so now let's come to what is called as a launch trial. Launch trial is head-to-head comparison of TACE with lenvatinib versus lenvatinib, and the study had impressive results with a good objective response, and even the median overall survival was also significant with a hazard ratio of 0.45. Therefore, TACE plus lenvatinib is the thing that you may think. So almost all the subgroups did benefit, and the subgroup what you can think of is those with a portal vein tumor thrombus. Again, there are different degrees of portal vein that you can think of. So lenvatinib plus TACE was safe and effective for patients with advanced HCC, and this can be used. And then this is the portal vein tumor thrombus. We classify portal vein thrombus to different degrees depending on how many branches were blocked. Now coming on to advanced HCC, So liver cancer is chemo resistant. You cannot give chemotherapy to it. So there are two ways to handle liver cancer. Number one is stop the blood supply to it by giving VEGF blockers, either tablets or injections. And the other one is to improve the immunity, immunotherapy. So immunotherapy and VEGF therapy. These are the two pathways how we handle liver cancer. Okay. So these are the multiple systemic therapy options you have. The first line treatment, you have 3 options. You have atezo-bev, you have sorafenib, you have lenvatinib. All these 3 are basically stop blood supply, and atezo has an immunotherapeutic effect, and you have multiple more second line options. and the combination of this is also coming up. So this is the first trial, sorafenib versus best supportive care or placebo. It did improve overall survival, 7.9, 10.7, very small numbers, pardon me. And Asia Pacific had further lower survival of 6 months, 6.5 months overall survival. The reason is Asia Pacific had more of hepatitis B population. Okay, so let's come to lenvatinib. Lenvatinib is different from sorafenib in that it has multiple tyrosine kinase inhibition, especially the FGFR is a problem. In liver cancer, the culprit is FGFR pathway. If you are not taking care of FGFR, these patients will not do well and you will not have durable responses. So if you have a drug that is FGFR4 inhibitor like lenvatinib, they do exceptionally well. So therefore, inhibition of FGFR is critical, and that is what lenvatinib does. And that is what REFLECT trial was, a non-inferiority trial comparing lenvatinib versus sorafenib. The study was positive because it was non-inferior. You can see the overall survival is 13.6 versus 12.3 months with a good hazard ratio. And you can see that numerically lenvatinib fares superior, and very importantly lenvatinib is better tolerated than sorafenib. And when you could take care of the AFP imbalances and the subsequent therapy imbalances, you can see the overall survival is 19.5 versus 16.3. Nearly 2.5 months improvement in survival. Whenever I am in a multidisciplinary team and I say my surgical and radiation oncology colleagues that I have a very expensive drug that costs lakhs of rupees that improves 2 months survival. They say for 2 months you want to spend $2 million, that's huge. So one thing what I would like to say is this 2 months is not for an individual patient. These are statistics, these are ways of getting approval. The patient in front of me may have 1 year benefit or even more than that. We do not know whether this patient belongs to the median, less than median or more than median. Therefore, these numbers are not for an individual. These are ways of getting drugs being approved. Just to say how important is these 2 months. So this is the photo of an Auschwitz concentration camp in Germany in 1944. So the uniqueness of this concentration room is the patients the people who enter, there is no exit door. They have to come out only through the chimney. They are burnt alive. That is how a concentration camp is designed. There is no exit door. If you want to come out, you have to come out through a chimney. So these are the people who are happy. It is not that they are released and they are free. They are entering into a concentration camp which does not have a chimney. That means they are not going to be burnt at least for a day. So they are happy. They may be burnt in the next day. But for them, 1 extra day of life also makes them happy. So I will always take this example to say, my colleagues, that 2 months of survival is big. If I'm going to die tomorrow and if I'm said you will live for 2 more months, it matters to me. So therefore, even 1 day of life is important in a patient who is dying. So these medians are not for individuals, and even 1 day of life for a dying person becomes important. And this is the example, the real photograph, how 1 day becomes important in these patients. Okay, let's come back to the data. So lenvatinib, non-inferior, and in fact numerically superior to sorafenib. So sorafenib is sort of obsolete right now. We are trying to use lenvatinib in almost all patients. Now coming on quickly to newer developments, atezolizumab. Atezolizumab is attacking both the pathways, immunotherapy pathway and the VEGF pathway. What happens when I combine both of these? There is improvement in overall survival. So at 6 months and at 1 year, more number of patients are living than compared to the sorafenib arm. So atezolizumab is the standard of care. The problem is bevacizumab is esophageal varices. Therefore, before you give bevacizumab, you need to do an endoscopy, seal those varices, and then only give bevacizumab. So these are the warnings before you give atezolizumab. And there is something called the Himalaya study. Himalaya study is durvalumab tremelimumab. It's CTLA-4 with PD-L1 versus sorafenib. Durva tremelimumab also positive again, there is around a 3-month improvement in overall survival. Durva, tremelimumab, Himalaya trial. If you have any patient who cannot take targeted therapies, you can use this immunotherapy combination, positive for both progression-free survival and overall survival. Coming on to second line drugs, I have failed lenvatinib or I have failed first line immunotherapy TKI combination, then these are the multiple trials you have: regorafenib, ramucirumab, cabozantinib, nivolumab, pembrolizumab, and so on. I'll just quickly go through the celestial trial: cabozantinib, improvement in overall survival, few months, but yes, statistically significant. Better responses: regorafenib, again this also improved responses and overall survival, again 2.5 months, statistically significant, hazard ratio 0.63. And then you have pembrolizumab and nivolumab, ipilimumab. These also did have an accelerated approval. Again, if you are not able to give a TKI, then you can give this drug for some modest benefit. So these are the options that you can give. So in the present day, these are the second line options you have. I give atezolizumab in the first line, second line you can give lenva or cabozantinib, regorafenib, and so on. So these are the priorities in front of my patient. When a patient comes in, sits in front of me, we need to ask him, what do you want? In his mind, money is going on. In his mind, family is going on. He's thinking what others are thinking about him. And he's thinking whether he has to change the doctor, he has to go somewhere, or he's thinking of the best food supplement. But cancer is the last priority probably in these patients. So we need to figure out what the patient actually wants and figure out not just the atezolizumab or the lenvatinib part, but also figure out what he actually wants and give him the best comfort, because after all, these patients are going to live for 1 year or so. So this is the reality versus a clinical trial data, In reality, you have a patient who is on a wheelchair with jaundice, whereas a clinical trial patient is just picked up 1 centimeter lesion on an ultrasound, and this patient makes a survival. So you need to really have a difference between a reality and a clinical trial data, because 60% of patients who come in my OPD are almost child PUC B or child PUC C who cannot even afford lenvatinib. So that is a real challenge. So liver cancer is a multidisciplinary team. I can just give lenvatinib or I can write atezolizumab, but taste, stare, radiology, biopsy, interpreting images, it's a multidisciplinary team. Multiple people are required. So MDT is the way to go for a liver cancer. So my conclusions are, liver cancer is a complex disease which I do not like to treat. Underlying liver disease is a big problem. Screening ultrasound is the way to go. Pick up early. Triple phase CT or MRI is the way to go. Biopsy is not required. BCLC is the way you should stage. Resection and transplant at an early stage. Otherwise, use liver-directed therapy like TACE, STAIR, SBRT. TACE plus lenvatinib has shown positive results. IO and VEGF are the two pathways that you have to target. Lenvatinib is the preferred TKI. Multidisciplinary team, optimal patient selection and sequencing can improve patient outcomes. So with this, I would thank all of you for your patient listening. I would thank Bengal Oncology for it. Thank you.